Good evening, Prof. Good evening, everyone. We are going to listen to Dr. Mariam, who is going to be taking the surgical anatomy of the large intestine. Dr. Mariam is a medical officer who is preparing for her primaries exams for surgery. She has registered with the West African College of Surgeons, preparing for her primaries exams. So we discussed with Prof earlier, and he encouraged us, including them in the presentation, so that if they have any challenges, they can pour down their challenges so that all those problems can be entertained and tackled. So Dr. Mariam, you are welcome, and you are privileged to present to this platform where Prof will be listening to your presentation and making comments after your presentation. When I told Prof about the topic, he said the large intestine cut across all levels of training, from primaries up to fellowship. So it's a welcome topic. Prof is our mentor, trainers of our trainers, and he's still active in impacting knowledge in the country and beyond. So you and your colleagues that will join are all privileged to share the same platform with this, our great mentor. So you have 30 minutes to make your presentation.
Thank you, sir. Good evening, Prof, consultants, senior registrars, and fellow colleagues. My name is Dr. Mariam, and I will be presenting surgical anatomy of the large intestine. These are the outlines that I will be following. I will talk briefly on the introduction, the parts, relations, blood supply and venous drainage of the large intestine, lymphatic drainage, the nerve supply, and some clinical correlations of surgical importance. So by a way of introduction, the large intestine is actually the most distal part of the gastrointestinal tract, which extends from the cecum up to the anal canal. It is about 150 centimeters in length and divided into several parts. The large intestine functions to receive digested food from the small intestine, from which nutrients have mainly been absorbed. So the large intestine absorbs water and some few salts, and then solidifies the stool to solidify the contents to make them into feces. And the rectum serves as a storage for the feces. Then this large intestine forms an arc which kind of encircles the small intestine. So based on the anatomical structure, the large intestine has some certain characteristic features that help in differentiating it from the small intestine. These features include having a wider diameter compared to the small intestine, the presence of epiploic appendices, which are fat-filled out pouches. And then there's also the presence of tinea coli, which are condensations of the longitudinal muscle of the large intestine, which unite at the base of the appendix and help in actually localizing the appendix during surgery when there's difficulty in finding the appendix. So you can simply just trace the tinea coli, it will lead to the base of the appendix. Then there's also the presence of hostrations. These hostrations or circulations are actually as a result of the length discrepancy between the colon and the tinea coli. The tinea coli is shorter, so this makes the hostrations because it's shorter than the length of the entire colon. Then also, apart from the differences between the small intestine and large intestine, even the large intestine differs. There are some characteristic differences between the right side of the colon and the left side of the colon, in such a way that the right side of the colon has a wider diameter compared to the left side. So as you progress from the right side to the left side, the diameter decreases. Then the contents also. The content on the right side is semi-solid, is liquid, sorry. The content on the right side is liquid, while as it progresses towards the left side of the colon, this contents become semi-solid or solid to form feces. So it's actually based on these factors that looking at colonic tumors on the right side hardly present with obstructive symptoms. They hardly cause intestinal obstruction because of the wider diameter. But then, and also the content is mainly liquid. But tumors that are on the left side mostly present, like rectosigmoid tumors, they present with obstructions because of the narrower diameter. So now looking into the parts of the large intestine. The large intestine has several parts, including the cecum with the appendix, ascending colon, the transverse colon, the left colic or hepatic flexure, the right colic or hepatic flexure, then the transverse colon, the left colic or the splenic flexure, then there's the descending colon, sigmoid, and rectum. We will look into each part separately. So now the cecum. The cecum is a blind pouch which lies intraperitoneally. It may or may not have a mesentery, and it is the most proximal and widest part of the large intestine. It is located in the right iliac fossa. So being the most widest part of the large intestine, it has a diameter that ranges between 7.5 to 9 centimeters maximally. So in patients with toxic megacolon, this diameter increases to as much as more than 12 centimeters. Then it's also of surgical importance in surgeries for intestinal obstruction, such that intraoperatively, when the abdomen is opened, if the cecum is found to be distended, then that obstruction is a large bowel obstruction, unless there is an incompetent ileocecal valve. And then when intraperitoneally the cecum is found to be collapsed, then that obstruction is likely to be a small bowel obstruction. Also, another special thing is the cecum has the appendix attached and receives the ileocecal opening, which is guarded by the ileocecal valve. Extending from the cecum is the ascending colon, which is the first part of the colon. And this part of the colon is only covered by peritoneum on the anterior and lateral walls, while the posterior aspect is actually plastered to the abdominal wall. So this makes it less commonly used for emergency colostomies because it is plastered to the anterior abdominal wall. It is about 15 centimeters in length and extends from the ileocecal opening, which is this. So this is the extent. It extends from here all the way to the right colic flexure. So this is where it ends. Then the transverse colon. The transverse colon extends from the right colic or hepatic flexure up to the splenic flexure. So from here, all the way here, this is the transverse colon. And this is actually the longest part of the colon, which is about 50 centimeters in length, completely invested in peritoneum. It has its own mesentery. So this is very freely mobile and a common site for colostomy. Also, it is connected to the greater curvature of the stomach by the gastrocolic ligament. Then the descending colon, this is about 25 centimeters in length and extends from the splenic flexure all the way to the pelvic brim. Also, the descending colon, just like the ascending colon, is covered on the anterior and lateral walls by peritoneum, while the posterior part is plastered to the posterior abdominal wall. Now, in about 20% of the population, the descending colon might retain its embryological mesentery. Also, the descending colon has more numerous appendices epiploiky, so is as well a common site for diverticulosis. After the descending colon is the sigmoid colon, which extends from the ending of the descending colon at the pelvic brim up till the commencement of the rectum, which is in front of the third piece of the sacral bone. It is about 40 centimeters in length, also invested in peritoneum and highly mobile. This is also a common site for colostomy. So because of the length of this sigmoid colon, the mesentery of the sigmoid colon may be so long in such a way that it might even twist on itself and present as a sigmoid volvulus. Because of the length as well, individuals with a lengthy sigmoid colon may present with recurrent constipation because of the long transition time of feces from the sigmoid to the rectum, resulting in more absorption of fluids and solidifying the stool. So that will present as constipation. Then the rectum. This is the most distal segment of the large intestine, which is about 12 to 15 centimeters in length, beginning at third sacral bone and ending at the apex of the bladder in males or the upper third of the vagina in females. Macroscopically, the rectum differs from other parts of the colon in such a way that it lacks tinea coli, it does not have hosturations, and neither does it have epiploid appendices. So internally, looking at the rectum, it has a characteristic somewhat like an ace-shaped curve. So internally, this rectum has two major flexures. I mean, on the exterior, it has two major flexures. This flexor and this one. So this is the sacral flexor, which is an anteroposterior flexor that is concave anteriorly and follows the shape of the sacrum and the coccyx. Then the anorectal flexor, which is this one, is also another anteroposterior curve, which is convex anteriorly and is mainly formed by the puton of the puborectalis muscle and functions mainly in continence of feces. So it's not just the external and internal sphincters that help in maintaining fecal continence, the anorectal flexor helps as well. So these are the two major flexors of the rectum. Then there are three more lateral flexors which are visible on the internal surface of the rectum. So these flexors, which are 1, 2, and 3, they give the rectum somewhat like a lazy E shape. And these inflections are actually due to the presence of the valves of Houston. And valves of Houston, the valves of Houston are formed by the transverse fold of the internal rectal wall. So then after this, there's the most dilated part of the rectum, which is the final part, which is the ampulla, which relaxes to actually accumulate and temporarily store feces until the defecation reflex is activated, and then there will be passage of stool. So the peritoneal coverings, the rectum actually has a specific type of peritoneal covering in such a way that the upper third of the rectum is invested in peritoneum anteriorly and on the lateral sides. Then the middle third is only covered anteriorly, while the lower third has no peritoneal covering as well. No peritoneal covering at all. Then the peritoneal covering now, in males, this peritoneum will now reflect, as seen here, it will reflect between the posterior wall of the bladder and the anterior wall of the rectum to form the rectovesical pouch. That's in the males. Then in the females, the peritoneum will reflect between the uterus and the rectum to form the rectouterine pouch or the pouch of Douglas. So now I will be talking about the several relations of the colon. So the cecum is related anteriorly to the coils of the small intestine, greater omentum, and anterior abdominal wall, while posteriorly it is related to muscles of the posterior abdominal wall, iliacus, the right psoas. Then it's also related to some nerves, the genitofemoral nerve, lateral cutaneous nerve of the thigh, femoral nerve. Then there are some important vessels that here need to be taken during surgery, the testicular or ovarian vessels. Then the ascending colon is related anteriorly, just like those relations of the cecum. Then posteriorly, it's also related to iliacus and quadratus lumborum. Then some three important relations here are the right ureter, the right gonadal vessels, and the second part of the duodenum. So care really needs to be taken especially during right hemicolectomy, such that these structures do not get injured because they are related to the ascending colon and can easily be injured. Then the transverse colon is also related anteriorly to the greater omentum and the anterior abdominal wall. Then superiorly, it is related to the liver, the gallbladder, and the stomach. And on posterior aspect, it is related to the second part of the duodenum, head of the pancreas, jejunum, and ileum. Then the descending colon is related to the small intestine, greater omentum, and anterior abdominal wall anteriorly, while posteriorly it has somewhat similar relations like the ascending colon, but the left-sided structures. So it will be related to the left kidney, left ureter, left gonadal vessels. So care also needs to be taken during left-sided hemicolectomy such that these structures do not get damaged. Now, the sigmoid colon is related anteriorly to the urinary bladder, coils of ileum, and the upper part of the vagina in females. Posteriorly, it is related to the rectum, sacrum, and ileum. Then the rectum, the rectum actually has different anterior relations in males and females. In the males, it is related to the rectovesical pouch, the sigmoid colon, the ileum, the bladder, prostate, and seminal vesicles. Then in the females, it is related to the rectouterine pouch, sigmoid colon, ileum, vagina, and cervix, which are separated by the fascia of the novelius. Then posteriorly, it is related to the sacrum, coccyx, middle sacral arteries, separated by the Waldeus fascia. So this is an important facial relation, the denomvelius and the Waldeus. The denomvelius fascia is anteriorly, while the Waldeus is posteriorly. So the importance of this fascia is such that it helps in rectal cancer staging because it serves as it forms the circumferential resection margin for tumors in part of the rectum that are not peritonealized. So now I will be talking about the blood supply of the colon. The blood supply of the colon mainly is from the superior mesenteric and inferior mesenteric artery, and this is based on the embryological development of the colon, such that structures derived from the midgut are supplied by the superior mesenteric artery, and the midgut extends from the point of opening of the major duodenal papilla at the second part of the duodenum all the way up to the proximal two-third of the transverse colon. Then from there extends the hindgut derivatives all the way to the rectum. So derivatives of the midgut are supplied by superior mesenteric artery, while the derivatives of the hindgut are supplied by inferior mesenteric artery. So if we look closely into this diagram, this here is the superior mesenteric artery, which is referred to as artery of the midgut and is derived from the abdominal aorta. Actually, just above this is the celiac trunk. So it's about 1 centimeter below the celiac trunk, and it's about the level of the lower border of L1 vertebra. It also has some important relations, such that this artery is related anteriorly to the left renal artery, the uncinate process of the pancreas, and the third part of the duodenum. So once the pressure within this artery increases, it might compress the left renal vein, which will lead to left-sided varicose. Also, because it is related to the third part of the duodenum, if it puts pressure on that part of the duodenum, it might result in duodenal ileus. But now, talking about the blood supply of the colon, this artery gives several branches, and actually the first 2 branches supply the small intestine, inferior pancreaticoduodenal artery, and the jejunal and ileal branches. But now we'll be looking at the branches which supply the large bowel. So the first branch that this artery gives is the ileocolic artery, which is this artery. So now this ileocolic artery, as it branches from the superior mesenteric artery, it will now divide into 2 branches, a superior branch and an inferior branch. So now this inferior branch will further divide and give cecal arteries, which will be anterior and posterior cecal arteries for the cecum that will supply the cecum. Then that posterior cecal artery is what will give an appendicular branch to supply the appendix. Then the superior branch now ascends and anastomoses with another artery. So that's the first arterial branch, the ileocolic artery, which is this one. So the second branch, which supplies the ascending colon now, is the right colic artery. As this right colic artery also branches from the superior mesenteric artery, it divides into an ascending and a descending. So now this descending branch of the right colic artery will now come and anastomose with the superior branch of the ileocolic artery. And then this ascending branch will now continue to supply the remaining parts of the ascending colon. Then the next branch is the middle colic artery, which is another artery that supplies the transverse colon. Now this artery also, this middle colic artery, will also divide. It will divide into a right and a left branch. So this right branch is here. This is the right branch, while this is the left branch. So this left branch continues to supply the transverse colon, while this left branch will anastomose with the ascending branch of the right colic artery. So as this left branch now continues to supply the transverse, and this is where the midgut terminates, then the inferior mesenteric artery will now take over. And the first branch of the inferior mesenteric artery, which is this artery, the first branch will now be the left colic artery, which is this artery. So as this artery also exits the inferior mesenteric artery, it will divide into an ascending and a descending. So the ascending branch of the left colic artery will now move upwards and anastomose with the left branch coming from the middle colic artery. Then the descending branch will continue to anastomose with next neighboring artery. Then the next artery from the inferior mesenteric artery is the sigmoid artery. Now this sigmoid artery will divide into several branches that will supply the sigmoid colon. It will give about 2 to 4 branches which will supply the sigmoid colon. Then this inferior mesenteric artery will now continue as the superior rectal artery to supply the rectum. So that is about. So the rectum actually receives blood supply from 5 arteries. A superior rectal artery, which is the termination of the inferior mesenteric artery, then 2 middle rectal arteries, which are this, and 2 inferior rectal arteries. The middle rectal arteries are branches from internal iliac artery, which is this, while the inferior rectal artery is a branch from internal pudendal artery, which is not shown in the picture. So one important structure that is formed by the multiple anastomosis that is formed is the marginal artery of Drummond. Now this marginal artery of Drummond, which is this entire thing, this is the marginal artery of Drummond. So this artery is also known as the marginal artery of the colon, and it is a continuous arterial arcade which is formed by the anastomosis of the terminal branches of the superior mesenteric artery and inferior mesenteric artery, as I showed in the previous slide. So from this marginal artery now, these straight arteries, which are known as vasa recta, will now go ahead and continue to supply the colon. So what is the significance of this marginal artery of Drummond is that it helps maintaining collateral supply between the superior mesenteric and inferior mesenteric artery, such that if any of the artery is stenosed or there is an occlusion, the other artery will take over and supply. Then another important connection between the superior and inferior mesenteric artery is the arc of Riolan, which is this arc. This is another communication between the superior and inferior mesenteric artery. But this one is variable. It's not present in all people. And another name of it is meandering mesenteric artery because it's not present in all. So it also helps in maintaining collateral circulation. Then there are the watershed areas of the colon. Watershed areas are sites of anastomosis between the superior and inferior mesenteric arteries, which have a high chance of anastomotic breakdown once an anastomosis is formed in those places. The 2 watershed areas of the colon are the Griffith's critical point and the Sudeik's critical point. Now, this Griffith's critical point is an area between left colic artery, which is this artery, between the left colic artery and it's an area between the left colic artery and the marginal artery of Drummond. So as this now, this left colic artery goes up to anastomose with this marginal artery of Drummond, almost at that, which is at the splenic flexor. So the importance is that it provides a communication between superior and inferior mesenteric artery. But then the clinical significance of this is that this anastomosis is a watershed area. Like, it is not a very significant anastomosis such that it will maintain the blood flow. And this makes this site a common site for ischemic colitis, because the flexor might be dependent on it. So if anything should happen, it will not be able to maintain the blood flow, and ischemic colitis can occur. Then the next part is the next watershed area is the Sudex critical point, which is another watershed area formed by anastomosis between the last branch of the sigmoid artery here and the superior rectal artery. So it's somewhere around this point, which is another critical point. And this is also another significant point, that if anastomosis is done, it might not survive and might break down, because this anastomosis is small and often a single anastomosis. But why the thing is, ischemic colitis is more likely to occur at the Griffith's critical point than in the Sudex critical point, because here it's just the superior rectal artery that's involved, but there are remaining middle rectal and inferior rectal and the superior rectal as well. They unite to form a mucosal plexus. So that mucosal plexus helps in maintaining the circulation and makes this area less common site for ischemic colitis compared to the Griffith's critical point. Then the venous drainage of the colon actually follows the arterial supply. So the ileocolic and right colic veins draining the ascending colon will drain into the superior mesenteric vein, while the middle colic vein draining the transverse colon will drain into the superior mesenteric vein. Then the descending colon will be drained by the left colic vein, which will drain into the inferior mesenteric vein. Sigmoid colon as well will drain into inferior mesenteric vein. Then the superior mesenteric and inferior mesenteric veins will now drain into hepatic portal system. Then the venous drainage of the rectum, the superior rectal vein, which is this, will drain into the portal system via the inferior mesenteric artery, which will then drain into the portal system. Then the middle rectal vein, which is this, and the inferior rectal veins, they drain into the systemic circulation, such that the middle and inferior, they drain into the internal ilia through the pudendal. So as it is coming, this rectal vein, as it is draining, it joins internal pudendal. Likewise, inferior rectal, they all join internal pudendal. Then internal pudendal will now drain into the internal iliac vein, which is systemic circulation. So the significance of this portocaval anastomosis is that once there's an increase in the portal systemic pressure, this site of anastomosis may inflame and will present as hemorrhoids. Now the innervation of the colon. The innervation is also dependent on the embryological origin. So midgut derivatives receive their sensory, sympathetic, and parasympathetic supply via the superior mesenteric plexus, while the hindgut derivatives receive their sensory, sympathetic from lumbar splanchnic and parasympathetic from pelvic splanchnic supplies, which are all components of the inferior mesenteric plexus. Then the lymphatic drainage of the colon. It drains into a number of several lymph nodes, which include the epicolic nodes, which are located so this are the epicolic nodes located on the bowel wall. Then there are the paracolic nodes, which are this, located on the they are located along the arterial arcades of the colon. Those are the arterial arcades. So the paracolic nodes are located along that side. Then there are the intermediate nodes, which are located around the corresponding mesenteric arterial branch. So if it is left colic artery, it will have its own intermediate nodes. Then ultimately, the final group is the principal nodes, which are this, that are located at the origin of the superior mesenteric artery and the inferior mesenteric artery. Now, lymphatic channels, which are proximal to the dentate line, will drain into inferior mesenteric and internal iliac lymph nodes. Then those from the upper rectum and the superior part of the middle rectum will also follow the superior rectal artery and drain into the inferior mesenteric lymph nodes. Then the middle to lower third of the rectum will drain also into the inferior mesenteric node or sometimes into the internal iliac nodes. Then areas that are distal to the dentate line will now drain into the superficial group of lymph nodes. Then we have what is called the sentinel lymph node. The sentinel lymph node is actually the first 1 to 4 lymph nodes that drain a specific site of the colon and are the first group of lymph nodes to receive metastasis in case of colonic tumors. Then the clinical correlations of surgical importance that I will be looking into will be the colectomy, colonoscopy, sigmoidoscopy, barium enema, large bowel anastomosis, colostomy, and colon bypass surgery. So there are several types of colectomy. Colectomy, which is the surgical removal of a part or whole of the colon. It could be a right hemicolectomy, extended right hemicolectomy, transverse, left hemicolectomy, sigmoid, total colectomy, or it could be a rectal resection. So now, a right hemicolectomy. This involves removal of the cecum, the ascending colon, the hepatic flexor, and the first third of the transverse colon, along with about 10 to 15 centimeters of the terminal ileum. Now, what this is based on, if this colectomy is actually based on the lymphovascular supply of that segment. So now, if a right hemicolectomy is to be done, the arterial supply and lymphatic drainage will be taken out completely. So now this is based on, it will be based on ligation of the ileocolic and the right colic artery. And sometimes the right, a branch of the middle colic artery. So this is about right hemicolectomy. Then there is extended right hemicolectomy, which is right colectomy, but extending up to the 2/3 of the transverse colon, and will include ligation of the ileocolic, the right colic, middle colic, and the ascending branch of the left colic artery, which is all the way to this place.
Mariam, you have 5 minutes.
Okay. Then in transverse colectomy, this is removal of the transverse colon, which will involve removal of both the right and the left flexors with ligation of the middle colic vessel, along with the greater omentum and transverse mesocolon. Then in left hemicolectomy, this will involve removal of the distal 1/3 of the transverse colon and parts of the sigmoid colon with ligation of left colic and upper sigmoid vessels and lymph nodes. Then in sigmoid colectomy, this involves removal of the lower descending colon all the way to the rectum with ligation of descending branch of left colic artery, and sigmoid vessels. Now, a rectal resection, this actually depends on the distance of a rectal tumor from the anal vag. So it can be done in any of these ways depending on the distance of the tumor from the anal vag. If the distance of the tumor from the anal vag is more than 10 centimeters, an anterior resection will be done. If the distance ranges between 6 to 10 centimeters, then a low anterior resection will be done. Then if the distance is less than 6 centimeters from the anal vag, then an abdominoperineal resection will be done. Then colonoscopy. Colonoscopy is the visual inspection of the entire large bowel. And the standard length of a colonoscope is about 160 centimeters, which is longer than the entire length of the large colon, the large bowel itself. So indications for performing a colonoscopy will be either for screening for colorectal cancers in patients with history or patients at risk. Then it could be diagnostic or therapeutic. So the preparation of a patient for colonoscopy will involve emptying the bowel, then and this involves bowel preparation. So how bowel preparation will actually start few days before the appointed date for the procedure, and this will include taking a low fiber diet, then using bowel cleansing agents such as mannitol to induce and laxatives, and then there is the routine use of antibiotics is actually not recommended, but depending on the clinical scenario and the patient, there might be need to use antibiotics. Then how you know that the bowel has been cleaned is once the patient reports passing clear liquid stool. So that preparation can then be discontinued, and the patient continues a liquid diet to the day of 24 hours prior to the time of procedure. So some basic rules that should be followed during colonoscopy include this, that the colonoscope should not be advanced without a clear view of the lumen. Then also the colonoscope should not be advanced if any resistance is felt. Then once there is doubt, it should be pulled back. Then also, air should be used as little as possible, but as much as necessary. Then also the pain reaction of the patient should be considered, and also a clearer view is actually seen during colonoscopy while removing the colonoscope, not while inserting it. So sigmoidoscopy, this is a less invasive procedure which only visualizes the sigmoid and rectum. It might be a flexible or rigid sigmoidoscopy. It will also require bowel preparation just like in colonoscopy, and this is actually just for evaluating sigmoid and rectal malignancy pathologies. Then barium enema. Barium enema is the radiographic study of the large bowel by administration of a contrast medium, with barium most commonly being used. It is reasonably accurate, minimally invasive, and requires no sedation or routine basis. So its preparation would also include dietary restrictions, such as taking low residue fiber diet for about 2 days prior to the examination, then use of laxatives such as castor oil, bisacodyl, and other laxatives, then of course bowel preparation. And then if the patient is taking any iron-containing medication, it should be discontinued. So there are two types. It could be a single contrast study or a double contrast study. Double contrast study gives a clearer, double contrast gives a clearer view and delineates more features than single contrast. And the difference is actually in the preparation. In single contrast, the contrast is introduced into the bowel and the images are taken. But in double contrast, the contrast gets introduced into the bowel, and then most of it is drained, and then air is used, and the images are then taken. Then large bowel anastomosis. This include attaching ends of structures together. So like there are three main types of anastomosis that could be done. It can either be an end-to-end anastomosis, where, so this is end-to-end, and in end-to-end, two open sides. This end will be open and this end will be open. They are connected and it will result in a seamless tube. Then in side to side, which is this, these two channels are connected side by side and their ends get closed. Then in end to side anastomosis, which is this, one open end is anastomosed to the other channel and the open end is closed. Then colostomy. Colostomy is the exteriorization of a part of the colon to the anterior abdominal wall for the main purpose of decompression or diversion of feces and stool. It is one of the most common life-saving procedures that's been done worldwide, and it could either be an emergency or an elective colostomy. It can either be temporary or permanent based on the indication for the colostomy. There are several types of colostomy depending on how the colostomy is being performed. It could be a Hartmann's colostomy, loop, divided colostomy, or end colostomy. Some complications that patients with colostomy may present with include surgical site infection, wound dehiscence, colostomy necrosis, retraction, diarrhea, and prolapse. Then there's colon bypass surgery, which involves using a colonic flap to bypass an esophageal stricture. Now, most of the time, the left colon is usually used, and this is so because the left side of the colon is more exposed to harder content than the right side of the colon. So it makes it easier to adapt function as esophagus. And then the colonic continuity after the left side of the colon has been removed is established by an end-to-end colocolic anastomosis. Thank you very much, and these are my references.
Thank you very much, Dr. Mariam, for this wonderful presentation. I must say you are really preparing yourself to become a surgeon. It has really shown in your presentation the passion you have for surgery. And if you will continue reading in depth for your preparation for your primaries, if you will go all through the topics outlined in the curriculum, I don't think you will have any issues with the primary exams. So I will open the floor for comments, questions, and contributions, after which our Prof will now make his final comments. So if you have any questions, any comments, contributions, you can indicate by raising a hand, then you will be given the floor. Thank you very much. Any questions, please? Prof, it appears the audience don't have any questions or comments.
Looks like the audience has gone to sleep. Because it looks concentrated.
Yes, sir. Okay, Prof, maybe we'll just...
No, Abdullahi has his hand. Kabir has a hand up. Dr. Kabir wants to make a point. Abdullahi.
Thank you very much. Dr. Mariam, can you hear me? Hello? Dr. Mariam.
Yes, you can
Yes,
go.
sir. Doctor. Yes.
All right. So thank you very much for the presentation. It was a very wonderful presentation. I benefited a lot. I have just a kind of a small question. You talked about colectomy. Colectomy. There's colectomy and there's extended colectomy. Is there any reason why the colectomy is extended? Because you haven't explained much about that part. You just explained how it's done. So is there an indication for extending it? Thank you very much.
Dr. Mariam, can you respond to that question?
Sir, I will try.
Okay, go ahead.
So it's actually based on the lymphovascular supply. So if there's chance that the malignancy or tumor might have extended, just to increase the margin of resection. But I'm not sure.
Okay, well, you tried, and that might be a little bit above your level. Maybe the registrars in the house that have been quiet. Dr. Magaji, are you with us? Dr. Magaji?
Yes, sir. Good evening, sir.
Yes. A question was asked by a medical officer also preparing for primaries that what is the difference between that right hemicolectomy and extended right hemicolectomy? Why the extension? And the presenter is not very sure of the answer she gave. I said it might be a little bit too much for her if you can help her out.
All right. I think she's correct, sir. It's for limited hemicolectomies are done for benign cases, while the standard right hemicolectomy and extended hemicolectomy is done for malignant conditions, so as to have a negative resection margin.
Okay, if you have a tumor in the cecum ascending colon, you know, right hemicolectomy is based on right colic artery. But if the tumor now extends to go beyond the ascending colon, maybe involving the hepatic flexure, you want to take more section of the colon for more to get a negative margin. So you extend beyond the distribution of the right colic artery to even include the middle colic artery. So you extend up to the proximal two-thirds of the transverse colon. So the right hemicolectomy, you take the terminal 10 to 15 centimeters of the ileum, cecum and appendix, ascending colon up to the transverse, the proximal 1/3 of the transverse colon. But for extended right hemicolectomy, you go beyond that, including the proximal 2/3 of the transverse colon. So a tumor that has gone maybe beyond the ascending colon, involving even the hepatic flexure. You want to take more of the colon to get a negative margin. Dr. Abdullah, is it clear?
Yes, sir. It is clear. Thank you very much.
Any other question?
I have a little contribution, and then I need a clarification.
Okay, go ahead, please.
With regards to the blood supply and drainage of the rectum, the inferior and middle rectal veins drain to the internal ileum and then to the system, while the superior rectal vein drain to the portal system. So if there is a tumor, a low rectal tumor, it will tend to metastasize to the lungs, brain, and other systems, as compared to a superior rectal tumor that will metastasize to the liver early. So based on the blood drainage of the rectum. So my clarification, I need a clarification in the branches of the superior mesenteric artery. While she was mentioning the branches, she started with the first branch to be the ileocolic artery being the first, the second being the right colic, and then the third branch, the middle colic. But I think it's the reverse. The middle colic is the first, while the right colic is the second, and then the ileocolic is the third. So I need a clarification on that.
Okay, Dr. Mariam, are you there?
Yes, sir. So actually, the blood supply, the superior mesenteric artery, the branches that I outlined in the image are actually just the branches that are concerned with the colon. The ileocolic, middle colic, and right colic are not the first. They are not the first branches. It actually, before giving the ileocolic, right colic, and middle colic, it has already given inferior pancreaticoduodenal and jejunal and ileal branches. So those are the first two branches. Then after that, there will be the middle colic, right colic, and ileocolic branches. If we are coming from up, down.
Dr. Magaji,
but if you ask,
Sir?
I said, is that clear?
In the text, there's a textbook I read. They labeled middle colic as number 1, then the right colic as 2, then ileocolic as 3.
Okay, the point she's making is these are branches that are related to the colon. There are other branches of the superior mesenteric arteries that are not even related. They are not mentioned here, like the superior pancreaticoduodenal artery is the first branch that is going up, supplying the duodenum and the pancreas. Then you have intestinal arteries, which are the jejunal and ileal arteries. They are coming from the superior mesenteric arteries. But because they are not, the question, we are not concerned with those arteries here. We are only concerned with the arteries supplying the colon. That's why you will see them mentioning middle colic, right colic, and ileocolic. But there are other branches, okay? There are 3 other branches that are not mentioned here. So it depends on how you want to number them. If you are starting from above downward, the superior pancreaticoduodenal artery will be the first. Then you have the intestinal arteries supplying jejunum. We have jejunal and ileal arteries. Then the middle colic arteries, then right colic artery, then ileocolic artery. Because the superior duodenal artery is coming from gastroduodenal artery, from up. So they now have anterior and posterior branch. They now anastomose with the inferior pancreaticoduodenal artery. So it's just depending on what you are presenting. These are not the only branches of superior mesenteric artery. Hope that is clear.
Yes, sir.
Any other comments? Or we'll hand over the floor to Prof.
Not see any other hand up here.
One more comment, sir.
Okay, go ahead.
The arc of Riolan is also a communication between the superior mesenteric and the inferior mesenteric, or the middle colic and the left colic artery. So the significance there is that if there is obstruction of one of these major named branches, blood tend to flow either in a retrograde manner or an antegrade manner. If there is a blockage in the superior mesenteric, the blood will now flow the other way around. So the vessel tends to dilate and become tortuous. If there is a blockage in the inferior mesenteric, it will now flow in a retrograde manner.
Okay, thank you very much, Dr. Magaji, who is a registrar with us in surgery and is aspiring to become a general surgeon also, and very hardworking. So we'll hand over the floor to Prof to make his final comment. Thank you very much.
Thank you very much. I think she's done well. You're right about what you said. Let me take what is low-hanging, which Magaji was making quite some point about. What the presenter described to us is, if you look at the anatomy, she's trying to show you where the blood supply, she's taking off from the ileocecal valve. In fact, the distal ileocecal region, and she's describing to us how the blood is going. And in continue with the anatomy, as she goes up the ascending column, she brings in the ileocolic, then she brings in the middle colic and the right colic. Sorry, the right colic and the middle colic. So she wasn't telling you exactly this is the first branch. If you go over that, you heard what Dr. Bashir said about the branches of superior mesenteric. So apart from the inferior pancreaticoduodenal artery, jejunal and iliac arteries, and then middle and right colic, and then ileocolic. So that's how it is. But the presenter was just showing you a diagram, and for you to understand where the large intestine begins, she started the blood supply from there. So she was right. She's not telling you anatomically where these branches, at what level they are rising. She's just telling you these branches exist, and she's drawing your attention to the fact that the ileocolic will supply the cecum, the terminal ileum, and a little bit of the ascending colon. So if you see that way, you then appreciate what she's saying. But let me get over to the rest of the presentation. Let me say to the presenter, when you are discussing about the intestine, generally speaking, blood supply is extremely important. And you won't discuss the blood supply in isolation from the embryology. So the embryology of the large intestine including the embryology of the vascular development, is extremely important in introducing this subject. You didn't say so. You only made small comments about embryologically, this is so and so. No, we would expect you to tell us about the development of the large intestine embryologically, and then when the blood vessels come in, and what happens when the blood vessels are not in the right way or do not develop properly. So that's a major omission. Your growth is wonderful. You describe the growth very, very well. In fact, there's nothing more to add about the growth. But you see, if you look at the topic you have presented to us, we also would have expected you to say something about the histology. Why do I say so? The intestine has got a muscle coat, and then inside it has an endothelial lining, and outside it has a serosa. We'd like to know about the embryology of those two. We'd like to know about the anatomical location vis-a-vis, the function. For example, where are the mucous glands more numerous? I would expected you to mention that. Why is this so? Because in the clinical anatomy of the colon, there is one of the very important things that takes place that we discuss, apart from malignancy you mentioned, is about hemorrhage. Why would hemorrhage occur? That's something that I thought you should tell us from the anatomy. What's the peculiarity of the blood supply? I'm happy you mentioned about the appendix epiploica, but you didn't tell us, you just mentioned that and you pass on. Nice to discuss that bit a little bit more. So, like I say, your growth was good, but the embryology was weak and there was almost zero histology. You should tell us why the colon has a lot of mucous glands. And as you come, you talk to us about the growth of the rectum. But you didn't tell us why it is there that absorption takes place. What is peculiar about the covering of the rectum that allows for absorption? So I think that area was missing. So I thought you dealt with the subject of lymphatic drainage well. When you come to clinical application, it's good to now tell us what you mean by the various levels of resection. But I know that because you are not yet fully in clinical surgery, you may have some little challenge in that area. So I leave that bit, but it's good to tell us what a level 1 knows, what a level 2 knows. So you try to talk to us about resection. I think you are biting more than you can chew. Suffice to say that resections that occur. Don't bother to describe in detail the resections. You can see somebody is taking you to talk about what right hemicolectomy and extended right hemicolectomy are all about. It's all because you were trying to say in a similar way, you were describing colonoscopy almost like a topic by itself. I think it's important to say that yes, it is possible to view the colon and do some procedures, both diagnostic and therapeutic procedures, but don't discuss too much about that. You almost gave the impression that resections are only for colonic tumors. No, there are other reasons for resection. It could be because of ischemia. It can be because of trauma. It can be also because of some chronic degenerative conditions that affect the colon. So Crohn's disease, ulcerative colitis, and so on are part of the reason. In fact, from our point of view, though we hardly do that now, chronic infestations can give fistulation that will require colonic resection. So just take note that colonic section is not only for malignancy. Malignancies are very important. I agree with you totally, but there are other conditions as well. So you finally spoke on diagnostics, including barium. Very important. Why do we go into doing colonoscopy? We go into the ileocecal valve. Is something you should mention. And then about the barium, I'm happy the way you dealt with barium. Now, you talked about bowel preparation, but you didn't give us the rationale for doing bowel preparation. So there is a mechanical component and then there is a bacteriological component. If you want to mention here about this, I think that's one of the things I would have expected you to mention. In other words, you described the growth very well. The embryology was not even there at all. The clinical anatomy, which is an important component of this exam process at this level, because if there's no clinical anatomy, then it's dry anatomy. So your clinical anatomy was also good, but I think you even took it, like Dr. Bashir said, you went a bit higher than you should have gone. It's important to say where bleeding occurs, hemorrhoids, sites of hemorrhoids. It's important to say where bleeding occurs a bit up, areas of diverticular, very good. It's important to say where bleeding occurs in case of vascular dysplasias. That's applied anatomy. It's important to talk where cancers commonly occur, very important. So those are areas of applied anatomy that are brought in the exam as part of the examination process. But I think on the whole, you have done very well. My last comment, which is, as I looked through, I discovered you really done well on your references. However, you only picked journals. I would have loved you to have picked a textbook of clinical anatomy. That would have added more information in the applied anatomy bits. So in this anatomy, we will expect you to give us location of the various segments of the colon. For example, if we're examining the abdomen, where shall we find appendix? Surface anatomy, that's the point I'm trying to make. So add surface anatomy to this, and then you will find that the presentation will carry more mass. For example, in the MCQs that we set for you, we will want to know something about surface anatomy of the various parts of the colon. For example, where is the splenic fascia? Where is the right flexure? Where is the appendix found? Where would the second most likely be? So that's what I thought we needed to mention. But I think you did very well in describing the gross anatomy. In fact, Bash, I didn't have anything to add about the gross. And I think it's a good effort. Take note of some of these points we have made. And if I were you, I'll revise this again in light of these areas we have mentioned and make it available to our coordinator. So Bash, I'll stop at that point. I don't blame her too much for the references. It's at the beginning stage, but for that reason, a textbook of anatomy should have been the basis for much of what she has said. Thanks.
Thank you very much, Prof, for these wonderful comments and contributions, which all of us benefit from. So, Dr. Mariam, I will encourage you to share this, your presentation with all your colleagues that are preparing for primaries, so that I think they can go through, and you can also share the slides with us and share with other colleagues. Then all those points that Prof mentioned, they can go through them and revise the topic once again. The video, the recording will be made available. So thank you very much, everyone.
Yes, Bash.
Yes,
Bash, let me make this final comment.
Yes,
She's done very well about, this is the large intestine. They should also pick up the rest of it. Read about the small intestine as well, and read about the vascular supply of the stomach or the upper GI. to complete the cycle of the blood supply of the GI system.
Dr. Mariam, are you there?
Yes, sir. Thank you very much, Prof.
Thanks.
Thank you very much, sir. Next week, our presentation will be management of acute pancreatitis by Registrar Dr. Deshi. So the link will be shared, and I will encourage residents to go through the topic as Prof always advise. So thank you all for participating. Thank you, Prof, for your time. We really appreciate. Thank you very much.
Thanks, and bye-bye.
Thank you, sir.
Yeah.